Welcome to Bad to the Bones, the podcast where we discuss everything related to orthopedics, joint health, and living an active lifestyle. Welcome back to Bad to the Bones. I'm your host, Debbie Rody. Today, we're going to take a closer look at how patients with pain are evaluated and treated in a real clinical setting, from the moment they walk into the office developing a personal treatment plan. Joining me today is Kaitlin Connelly. She's a physician assistant with Premier Orthopaedic Associates. Kaitlin has a tremendous amount of experience helping patients who experience both acute and chronic pain. Kaitlin, welcome to the show.
Thank you.
We're excited to talk to you today. We really are hoping to share with listeners, your experience and just kind of get some background about how a patient will be evaluated and how you develop a treatment plan. So let's get into it. We know every provider rather, has their own philosophy about, how they care for a patient. Can we take a look and just walk through what your approach is to improve a patient's overall function?
Sure. So one of the biggest things I try to focus on is that the approach has to be very personalized.
Yeah.
Because pain is not a one-size-fits-all type of thing,
Yeah.
Everybody perceives pain a lot differently, where, a patient could have the same exact diagnosis and as another one, and they can feel it the complete opposite ways.
Yeah. Meaning their level of pain, if you were to say 1 to 10, or just in different places, or both?
Both.
Yeah.
Absolutely.
Yeah. So when a patient walks into the office to be diagnosed for this pain, what are some of the important things that you're trying to understand during the initial evaluation?
So obviously the most important part is their history. So things like, when did the pain start? Where is it located? Is this the result of an injury, or did this happen progressively? So there's one thing, a mnemonic phrase that I'm sure anybody who went through either PA school or medical school has been taught. It's back to basics.
Yeah.
It is, the letters are P, Q, R, S, T.
Okay.
And so the P stands for provoke or palliative. So what provokes the pain?
Okay.
And what is palliative? What makes it better?
Yeah.
The R is for radiating. So where is it radiating to?
Mm-hmm.
The Q, I'm sorry, let me back it up.
No, that's okay. Go ahead.
The Q is for quality. So is it sharp? Is it dull? Is it achy? Is it stabbing? The S is for severity, which everybody uses this, the 1 to 10 pain scale.
Yeah.
Again, everyone's is vastly different.
Yeah.
And then the T is for timing. So is it constant? Is it intermittent? When do you feel it the worst? Those type of things.
Is that acronym something that you actually explain to the patient? This is this, and I'm going to go through each of these, or do you just kind of do it in your head and outwardly?
Exactly. It's sort of second nature to me at this point.
Yeah.
But it really does give you a good guideline for just important things that you're going to need to know.
Yeah. Do you find that when you're asking those questions, I know from my own personal situation, sometimes it's difficult to determine where the pain is coming from, or maybe the day I'm seeing you, the pain is at a 5, but yesterday it was an 8. So do you find that you run into that, and how do you handle that?
Yeah, I run into that a lot.
Yeah.
And that's kind of what we're here for. We're here to help patients kind of work through it.
Yeah.
And figure out, where is the most pain that you feel, and where most frequently do you feel it, and just kind of hone in on the specifics.
So once you've gathered the history, and I'm assuming you've completed a physical exam as well during that initial visit. Does that take place, the physical exam during the initial visit? Okay. How do you begin to actually find out what is causing the pain just at the physical visit?
So typically, before patients get to me, they have at least had some sort of imaging study, usually an X-ray.
Yeah.
Sometimes no, but most of the time, yes. And, that is a huge help
Yeah.
in diagnostics,
Yeah.
right? And then we sort of piece it all apart and decide if there needs to be a more extensive imaging study, an MRI, a CAT
Okay.
scan, and just to kind of figure out, exactly what the pain generator is.
What is the determining factor as, you're looking at the x-ray, you've done the physical exam, and you now say to yourself, this patient probably needs an MRI. What is it that makes that next step?
So there are specific things, or I guess like keywords that patients would say that gives you an idea. Maybe this is more of a soft tissue injury or something that we wouldn't necessarily be super obvious on an x-ray.
Yeah.
Or, if the x-ray, after looking at the images, reading the radiology report, it looks completely normal.
Yeah.
And that means, we need to dig a little deeper and try to figure out what's going on.
So as you are starting to develop a treatment plan, is the treatment plan developed before, like if you had to send someone for an MRI, are you still developing a treatment plan in that in between time?
Not necessarily.
Okay.
I usually, just to kind of give patients a peace of mind, maybe give them a short, okay, if the MRI shows A, we will do B.
Yeah. Yeah.
Just to kind of calm some nerves and try to keep, the patient positive that they're going to be able to get rid of some of this pain.
Yeah. And then once you get all of your imaging to evaluate, to really develop the treatment plan, what factors influence how you decide the treatment plan? And if it's easier for you to kind of pick a situation to like a body part or an injury or whatever
Sure.
to work on, we could talk it that way if
Okay.
it makes it easier.
I mean, one of the biggest things that we focus on is the patient's goal,
Yeah.
and specifically, how their pain is affecting their daily life
Yeah.
and their level of functioning. So if the pain is making it so they can't go to work, or they can't do chores around the house or things like that,
Yeah.
then okay, we have to try to tailor a plan that is going to fit into the patient's life,
Right.
not necessarily vice versa. Like, we don't want them to have to fit the plan.
Yeah. But when you say treatment plan to fit their life, it's not like, well, I'm not sleeping at night. So does that mean you're going to develop a plan that gets them to sleep at night?
Possibly.
Okay. Yeah, because I mean, it's just curious. I think patients, when they say, a personalized plan, what does that actually mean?
So one thing I ask patients a lot of the time is, what is the biggest
Outcome or
what is the biggest problem that this pain is causing for you?
okay, yeah, that's good.
If we could eliminate one thing,
Yeah,
what would it be today?
right,
At
right.
this second,
Yeah.
right?
And what are they saying?
Right,
Like,
someone
I
who
just
hasn't
don't want
slept
to
in a
be pain.
week,
Yeah,
sure, that is their biggest,
yeah,
their biggest contributor.
right.
So, all right, maybe we talk about some medications that could help.
Yeah,
Or maybe we talk about a different position they could sleep in,
yeah,
using heat, using ice, all, sometimes things as easy as that can
hmm
really make a difference.
When you find that people aren't sleeping at night, is that a huge factor in influencing? Because maybe when they're lying down and it's more painful, is that like an indicator like, oh, wow, something,
Sometimes,
right?
yeah.
Like,
Definitely with a lot of spinal problems.
yeah,
Um, I know, actually today I spoke with a lot of patients who were either pending or post-op shoulder surgery. So sleep was a big thing because laying flat is not really an option,
no,
or on your side,
yeah,
whether it's the side that's affected or the opposite one.
yeah. So many patients, as you kind of just said, they want immediate relief, right? So how do you work with a patient to set realistic expectations, especially while they're in all of this pain and the process is going on with getting extra imaging reports and you just figuring out what the best approach is? How do you meet their expectations
So,
or set them?
right. Sometimes the conversations can be very difficult
Yeah, I'm sure.
because sometimes, you're right. They do expect immediate pain relief from a problem
Yeah.
that may have been going on for several weeks
Yeah.
or potentially longer and just not really causing any symptoms yet.
Right.
So this problem could have been happening for years, and so we have to talk things out.
Yeah.
We have to, again, try to focus on the day to day rather than what's going to happen next week.
Yeah.
Yeah. Which can be very difficult sometimes.
Yeah, I'm sure. And so many of the patients, when they think of pain management, they probably are thinking, oh, I'm just going to get some medication for this, or they're going to give me some sort of procedure. But in many cases, you like to practice conservative care first, correct?
Absolutely.
Okay.
Yeah.
So what does that look like?
So one of the biggest things is physical therapy.
Yeah.
Whether that is to the extent of formal physical therapy, in an office setting, or sometimes physical therapy can go into the home, or it could be as basic as a home exercise program,
Okay.
or a stretch regimen, or things like ice, things like heat, things like bracing, or even like electric stimulation.
Mm-hmm.
All these things are done at home and are really a important thing to incorporate because there's never just one thing that's going to fix it.
Yeah, I'm sure. Especially like you said, someone who has had pain for months or weeks or years, it's just not going to be turned around overnight. But these patients, want to know the steps, and I like that you seem like you're very in tune with that, to explain how that process is going to go. So when you decide what are the next steps to go to if maybe they're not improving in 2 weeks, or what's a time frame like that you would say is average?
I guess it depends on the problem,
Yeah.
but typically, whether it's something as simple as trying a medication,
Yeah.
then I usually like to give it at least a week or two to see how the patient will respond.
Mm-hmm.
They may have an immediate response, which is wonderful.
Yeah.
Or, it may take a few days. And I always encourage them to reach out to me and let me know what's going on. If they think that in 5 days they should have seen a benefit,
Yeah.
that's okay. And if they haven't yet, it's also okay. Then, we might just have to continue it a little longer.
So is there a different approach between acute pain and chronic pain, or acute, or like an acute injury, or is there a difference on your approach?
Absolutely. I think that a lot of the time, if there is an acute injury, or in my case, more often, like post-operative pain,
Mm-hmm.
then we are treating the focal injury,
Yeah.
or surgery, rather than sort of focusing on, I guess, the bigger picture or long term.
Mm-hmm.
But with chronic pain, the focus sometimes can be not just on the one, I'll say, severe arthritis in the knee, right?
Right.
I think it becomes a lot more of conversations on how this limits me, and frustration, and sort of, what different methods to take.
Yeah. And how do you handle when a patient is saying movement hurts, but movement is actually what's going to help them?
Right.
How do you work around that?
Right. Well, there is something to be said for the don't use it, you lose it sort of saying.
Yeah.
However, there are some times where that mindset isn't always the best way, only because if you just had surgery and, doctors are telling you, nope, you need to be in that brace, you cannot move your arm,
Yeah.
that's how it has to be, then that's what you got to do.
Yeah. Yeah. And what about patient education? Education seems like it is a big part of pain management, and we've begun to talk about that a lot of how you're trying to educate your patients about the whole process and whether movement is good. What are some of the misconceptions that you see with patients on how their body is supposed to or could probably respond to treatment?
Um, Sort of going back to what we said before, the immediate pain relief,
Yeah.
right? I don't always think that patients realize that there's not just one component to their pain.
Yeah.
So whether or not, they're having pain from inflammation or muscle spasticity or neuropathic pain,
Mm-hmm.
we kind of have to piece it apart. And it might be that, we need to incorporate specific medications, specific stretching, specific exercises, and all of that as a combination
Mm-hmm.
is what's going to help, not just the one pill or the one stretch
Yeah.
or whatever it may
Yeah.
be.
So based on just a generalization, I mean, are you seeing patients um, once a week when they're in these treatment plans, or is it like every 2 weeks? I mean, I'm sure it varies based on acute or chronic injury and even just the pain itself.
Right.
But what does someone typically expect?
Um, Sometimes every 2 weeks,
Okay.
mostly monthly.
Oh, okay.
If they have already sort of begun their treatment with either whether it's one of the orthopedists or one of the interventionalists, or even if they're just doing physical therapy, then of course everything takes time.
Yes.
So we try to space that out. But obviously, if there are changes that need to be made, we bring them in whenever we have to.
Yeah, I like that. And without sharing personal details, do you have a patient story that you might be able to share with our listeners of someone that was really, just struggling and you really gave them their life back, turned things around for them?
Um, yeah, I do.
Yeah.
I have a patient who actually, this was just recent. Um, he injured himself being physically active, lifting really heavy things, and otherwise was a young, very healthy person,
Mm-hmm.
and ended up having a pinched nerve in his back, and I guess this had been progressing for some time, causing zero symptoms. And, it took one movement, one twist, one lift, and immediately set his symptoms off.
Oh,
It was very acute. When I saw him, he was in severe pain, barely functioning, barely walking. And the first day I saw him, I was barely able to complete a physical exam. That's how severe his pain was.
oh, wow.
And I even, in my, talkings with him, I even did suggest potentially sending him to the ER because he was in that much pain. But he toughed it out, and we did start him on, I think it was 2 different medications, and got him in with one of our spine surgeons relatively quickly.
Mm-hmm.
And by the next time I saw him, he hadn't had any procedure or surgery yet, but he, I would say, was 70% better.
Nice.
Just from, some very mild medications.
Mm-hmm.
And he had started physical therapy, but
Okay.
from what I understand was, keeping it very, very light because of the intensity of his pain.
Yeah.
So then by the second time I saw him, I'm sorry, third, he had underwent surgery
Oh, gosh.
with one of our spine surgeons,
Okay.
and it was like night and day.
Okay.
He came to me, and this also does not happen very often, where I can sort of like wipe my hands
Yeah.
clean,
Yeah.
because he basically came in to say thank you.
Oh, that's great.
Because he was like, I don't need refills. I'm done with my medication. The surgeon had already cleared him
That's
to get back to
fantastic.
being, more physically active.
Yeah.
And, he was really happy.
So what was his problem? What was the
He had a very large I'll use the word extruded disc
Oh,
in his
gosh.
lumbar spine. That what that means is that it's basically crushing or intensely impinging one of the nerves, and was sending pain from his back all the way down his leg to his toes.
Oh, man, that's
Yeah.
horrible. Wow. So did the medication, does that just reduce swelling or just kind of calm the nerves or
So
both? Like,
exactly.
yeah,
I believe that I had started him on an anti-inflammatory medication and then a muscle relaxant,
yeah,
which are medications that can sort of be started very quickly and stop quickly without
yeah,
having to taper the dose or
yeah.
wean off necessarily. So, as sort of a not knowing what was to come,
Right.
it was sort of the best way to get him more comfortable. And the fact that he was able to just discontinue completely, like
That's
I think it was
fantastic.
about a week after surgery,
Yeah,
was really cool.
that's really great. That's a really great story.
Yeah.
Very nice. Caitlin, thank you so much for sharing your insight today. Is there anything that you'd like to share with the listeners as, just speaking to someone out there who might be in pain, maybe just is dealing with it?
So, one of the biggest things that day to day that I address with patients is something that I think gets overlooked a lot, and it is the effect on your mental health
Mm,
that pain can cause.
yeah,
Um, you know, being in, there's not many people I know who like being in pain, right?
right, right.
And immediately, it can send anxiety and stress levels through the roof. And I mean, it's not just something that people say, it is actually, a scientific fact that chronic and high levels of stress change the way your brain perceives pain.
Mm,
So it lowers your pain threshold and makes it really difficult to deal with.
yeah,
And then the cycle continues, right? So pain increases, anxiety increases, pain increases, and if nothing breaks that cycle, that's how it's going to be.
mm,
So it's really important to address those things and, address frustration, acknowledge it, and try to just, again, remind patients that, um, we need to look to tomorrow. We're not going to look to next month, next
right,
week,
right.
whatever it is, and just take it day by day. There's going to be days where it's not going to be good, and there's going to be days that are going to be a heck of a lot better.
Yeah.
Yeah.
Yeah. I like that. That's a really good message because obviously mental health is a huge topic.
Right.
And people in pain, I mean, it can really, I've seen relatives who are getting older and they're just having chronic back issues and it's just wreaking havoc on their whole life.
Absolutely.
So I like that message. Thank you. That's a
Yeah.
good way to say, to our listeners that you don't have to live in pain like that. There's options.
Absolutely.
So thanks again for sharing your insight. We really appreciate having you here
You're
today.
welcome. Thank you for having
And to our listeners, thank you for tuning in to another episode of Bad to the Bones. If you've enjoyed today's episode, please share and subscribe so you can stay in touch with everything joints and muscle and pain related. If you're experiencing pain, feel free to call us and schedule an appointment. Kaitlin is the best. She really is. You can call or text us at 856-690-1616 or visit us online at poasnj.com. Until next time, stay strong and keep those joints moving.